All righty. I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series, but I'm also a patient living with MPA ANCA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsor, Novartis, for supporting these webinars. Today's webinar is a great 30-minute question and answer session about Behcet's with Dr. Andrew Sulich. Dr. Sulich previously helped us out with a great informational webinar about Behcet's that is currently showing on the Vasculitis Foundation's YouTube channel. So if by chance you haven't seen that yet, I encourage you to go watch that after today. And we're following up that with the opportunity for patients to actually ask him questions about Behcet's today. So after we finish this webinar, there will be a recorded version of this also on the Vasculitis Foundation's YouTube channel, and everyone who registered will get an email with a link to it as soon as it becomes available. And let's begin by introducing our speaker for today. Dr. Andrew Sulich is the Chief of Rheumatology at Henry Ford St. John Medical Center in Detroit. He's an assistant clinical professor at Oakland University William Beaumont School of Medicine. Dr. Sulich is a rheumatologist in private practice at Shores Rheumatology at St. Clair Shores, Michigan. Dr. Sulich is the Fellow of American College of Rheumatology and a board member of the American Behcet's Foundation. I hope I got that all correct, Dr. Sulich. I'm so happy to have you here today.
Spot on. And I don't even get paid for those jobs, so that's great. But I appreciate the accolades and reporting them to me as well. I didn't even know I had a YouTube channel. I didn't know this was my presentation was on YouTube. So don't forget to ring that bell, right?
It is, and it's just great. I
Okay, thank you.
rewatched it.
All
We
right.
did a great job on this
All
prior
right.
to this. And I did want to ask you before we get started if you have any disclosures to share with us today.
No, not with Behcet's. I don't have any conflicting. Although we do clinical trials and we did the relief trial, which was with a Premalas, but not. I don't have any conflicts. I'm not doing any Behcet's trials right now.
Okay. Well, then we're going to get started, and I encourage everyone to find that Q&A box and put your questions in there. I do have some questions that have been submitted in advance by patients that we thought we would start with while we're waiting to gather those from those of you that are here. So let me start with the first one of those, and that is, are there differences in how Behcet's affects men versus women or younger versus older patients?
Yes, there are differences, but they're also primarily rooted in geographic distribution. So by far, we typically see that the more severe disease manifestation happens in males, but it is more prominent we see in Middle East and some Far East countries like Japan. So it tends to be younger and male in that group, all right? So that has the most severe disease. However, we all define severe disease differently. In rheumatology, we think of the catastrophic vasculitis that occurs in these patients, but there are also the people that have recurrent mouth ulcers who never developed those vasculitis can be severe as well. So in general, you think men and males, younger patients tend to be more problematic and have worse disease, but it's more geographically rooted, Middle East and Japan, than it is here in the United States. Keeping in mind, though, we're having an influx immigration that may change in a couple of years.
Interesting. The next question is, are there specific lab tests or imaging techniques that help confirm a diagnosis, or is it still largely clinical?
It's always been clinical. The problem with using lab tests in terms of Behcet's disease is that we've not come up with a single test that I say is that this we call is diagnostic. Behcet's is like a puzzle, and you kind of put it together in pieces. You hope the pieces are, oh, sometimes the pieces are not there. When we do puzzles with my wife, sometimes you do a puzzle and the pieces are not there. So how do you know what person has? So it's clinical diagnosis. Now, sometimes doctors may use, laboratories, and they will typically check for inflammatory markers like CRP and SEDRA. Sometimes they'll do the pathergy test. We're familiar with that test, where you take a 27 gauge needle, or sometimes when you have your blood drawn, there's a little pustule that forms, okay? Is that common in Behcet's patients? Not in the United States as much, but in the Middle East it's much more common. They may do a genetic test on you, and it's called HLA-B51. The problem with doing that test is that not everybody carries the gene, so it can't be a diagnostic test. It's more for classification purposes. And so it really comes down to where you're from, okay, what's your genetic background, and how your severity of your disease is how we follow you clinically. But there's still no laboratory studies that say, yep, you have Behcet's. Now, if you have severe disease, okay, and going to the other side of the coin, if you have vasculitis, which is inflammation of the blood vessels, large vessels, if I see that in the pulmonary artery, that's almost always Behcet's. If I see a uveitis in the eye, severe, which involves the entire eye, I'm very suspicious for Behcet's. Or in the United States, it could be sarcoid. So there's certain things that present, and you say, oh, that's unusual. That may point more to Behcet's. But when you come with, let's say, mouth ulcers or some non-specific joint symptoms, that may not point to that. So there's where the challenge is.
Interesting. We do have a couple of questions coming in. I'll start with the first one. How many Black people with Behcet's do you see? How much rarer is it to have both Behcet's and Sjogren's?
So I've seen Sjogren's before because Sjogren's is common. Okay, let's be honest, it's much more common than Behcet's. So it's not unusual to have someone present with Sjogren's syndrome and possibly get Behcet's. Have I seen it personally? No, I haven't. Simply because again, I see mostly more men, probably about more men. We typically see more Sjogren's than women, but it's quite possible it can happen. You just want to make sure that that's Sjogren's that they're diagnosing you with. That's because if you have parotid enlargement, like I said, it could be sarcoidosis. If you're African American, that also raises the issue of could it be sarcoid and not Sjogren. So there's a lot of questions that you have to answer when you see a patient. Now, if you see, have I seen in Behcet's in African American? Yes, I have. So there are regions in Africa they've reported, not so commonly, but here in the United States, particularly if there's any ethnicity from the Middle East, you can. So African American does not exclude you from having Behcet's at all. Here in the United States, though, again, it's mostly we see in mostly Caucasian patients. But it's kind of because it followed the Silk Road, so to speak, as our gene heritage. And you also have to be careful. You also see them in patients, Korean and Japanese patients.
Interesting. And I just want to ask, and this is just for me, does every patient who suspects they might have Behcet's, if are rheumatologists very familiar with this in general? Is it easy for them, or do they have to go to a specific type of rheumatologist or center?
Rheumatologists are familiar with this with the most severe phenotype. When I say phenotype, it's how you describe and see a patient, okay? How their illness presents, all right? So the severe phenotype is a fulminant vasculitis. As you mentioned before, as you disclosed, when you talk about GPA and MPA vasculitis, that's a certain kind of vasculitis, and that has an autoantibody with it. When you talk about Behcet's disease, it is a panvasculitis. It involves the small the veins, the small arterioles, and then the large arteries. And it can involve the large veins. That's where the blood clots come from. So you have to understand that it is a panvasculitis. And so rheumatologists, when you walk in a room and somebody has uveitis, central nervous system disease, pulmonary arteritis, they can recognize as being Behcet's, okay? But a lot of times in rheumatology, when they see people initially with recurrent mouth ulcers, they'll probably think it faster than somebody that's in the private practice. But again, they suffer the same challenges we do, is that many patients come in with recurrent ulcers, but don't fall into criteria yet. And we're a little bit hesitant in calling them Behcet's.
Interesting. Um, One of the patients is asking, do seasons of the year, temperatures, barometric pressure, humidity, etc., impact Behcet's activity?
Depends which activity you're talking about. I've not, the joint symptoms seem to be impacted the most. If they have joint disease, if it goes on to become seasonality. I have not seen Behcet's present in a seasonal fashion. There's no season for Behcet's, but I've seen that's probably the biggest impact. In terms of the mouth ulcers, it's so random. It can happen at any time of the year. So it's not, I've not seen it, that kind of pattern. It's mostly the joint symptoms that typically I would say are the most impactful in terms of seasons.
Okay, and are there commonalities between SLE and Behcet's? Is it possible to have Behcet's and an ANA negative SLE? I don't
Okay,
know what any
so
of that is.
okay, so there's a lot to that question. So let's unpack it a little bit. First of all, lupus can present with mouth ulcers, and lupus patients initially tend to present the vast majority with mucocutaneous and joint symptoms, and non-specific symptoms like, as I said, fatigue. So we see a group of lupus patients presenting in such fashion, okay? And then let's take the Behcet's patient who presents recurrent aphthous ulcers. So in the beginning, there may be some overlap in clinical presentation. You say, oh, this is interesting. This may be a person with lupus, or this may be a person with Behcet's. The advantage of lupus, if you want to call it an advantage, is it is an autoimmune disease. I don't mean by means when we say autoimmune, there is autoantibodies that we can detect. So you mentioned the word ANA negative. ANA negative lupus can occur, but it's a very specific type of lupus. It usually presents with their general ANA is negative, but they have an SSA antibody, which is typically positive. So as a result, you have to go back to your clinical features. If a patient walks into my office with recurrent mouth ulcers, no eye disease, photosensitive rash, okay, they present with symmetrical polyarthritis, that patient is most likely to fall into a lupus category or rheumatoid, or predominantly, let's call it lupus for now. Where if I have someone who presents with recurrent mouth ulcers, maybe a fleeing type joint pain, folliculitis, pathargy, maybe uveitis in the past, that's going to fall into more Behcet. So you see, we tend to put people in kind of buckets, so to speak, but in the initial presentation, it can be very tricky. And that's why we don't want to label you. People say, I get people very frustrated with me and say, well, can I have a diagnosis? Once I label you, you're going to be followed down a track, okay? And no one is going to think maybe it's something else. So you can imagine we have these things called EMRs, or electronic medical records. They follow you everywhere. So if I put the word Behcet's in there because I see a young woman that presents with, let's say, recurrent mouth ulcers and maybe some joint symptoms and may even have a positive ANA, and I call that lupus, okay? That patient is going to be tracked as being lupus, but that may not be. She may be a Behcet's patient. So we as rheumatologists tend to be very, very just sort of ambiguous in the beginning because we don't want to prematurely label you. The other aspect of that is if we label you, let's say Behcet's, you try to get life insurance or you try to go out and get it, they'll say, oh, I'm not going to touch you. You got Behcet's. That's this is a severe disease. So there are ramifications of premature diagnoses. And you can't kind of undiagnose it. You can't take it out of the MR. It's like taking a pillow and ripping out the feathers and throwing them out and say, collect them later on. It's not going to work that way. So the biggest challenge, I think, it's a frustration for patients. I get this. But I never want to be down a road where I say, well, I diagnosed you as lupus, but you really have Behcet's. You don't want to do that.
I really appreciate you taking the time to explain that to us because it makes so much sense to hear you say that at this point, but I never would have understood why we didn't go ahead and get the diagnosis. That makes so much sense.
Well,
Thank
unless
you
you're
for
the
that.
patient. Now, if you're the patient, in all fairness, the patient's sitting there saying, because you know how everything is in medicine is, well, you got bronchitis, you get a chest X-ray. If you've
Yeah,
got, if you got chest pain, you get a heart workup. But we get that. But that's not the kind of medicine Behcet's patients are all about. You're having an illness that has multiple domains that may never occur, and it progresses over time. And so that's a challenge, and that's why I say lupus is an autoimmune disease. Technically, Behcet's is an autoinflammatory disease. It doesn't have the antibodies that we've been able to detect yet. So that's why we don't have a blood marker. You have, again, I keep going back to you, Kathy. You have a blood marker. You have an
right.
anchor. You have a specific antibody, and that's why they call it an autoimmune disease. Where I call Behcet's is autoinflammatory disease, and it doesn't mean it's any less severe, but it just means that we don't have those biomarkers that we'd like to have because that would help us make the diagnosis.
Right. Okay, moving on to the next question. Someone's asking, are there any new medications or trials on the horizon for treating Behcet's that seem promising?
There are plenty of trials that are in the market right now. There's two kinds of trials that are going on that I know of. One is for the oral ulcers. So some companies are trying to tackle this situation because they fully realize that not every patient with Behcet's is going to progress to vasculitis that will require some of the more aggressive therapies that we use. So the market, remember, we're dealing with rare diseases, okay? So where's the market in a rare disease? That's the challenge to it in and of itself. You're saying to myself, well, if I'm going to go for psoriasis, because there's 6 million people in the United States to 10 million have psoriasis. We have 5 per 100,000 Behcet's. So you're dealing with an orphan kind of approach. Now, there are provisions of orphan treatment, and so sometimes they're supported by the government, sometimes not. But the trials are designed to, number one, looking at the oral ulcers. So they're looking at different compounds that could be helpful, both regional, the topical, and systemic, to be able to help the oral ulcers. Then there are trials that are coming out that are basically investigator initiated, meaning that a drug company may not be doing it, but maybe a private institution is doing it, or a medical school is doing it, like Columbia or Mayo or something like that, where they have their own trials. And what they're doing is borrowing from drugs that are already on the market. So for instance, it's interesting, they kind of borrow from a whole potpourri of things. One, they're borrowing things from JAK inhibitors that are currently on the market. They're borrowing from a drug called ustekinumab, or Stelara. They're looking at the IL-17 drugs, and these is Cosentyx and those kind of. So there's my plug for Novartis, right? I mean, though Cosentyx is not indicated for Behcet's, but the point being is that they're looking into seeing, well, if these work in these conditions, will they work, obviously, in conditions that Behcet's have commonly, which are mouth ulcers, skin disease, and joint disease? So there are ongoing trials. And there are also trials that are investigating, looking at different compounds. But the problem with doing randomized controlled trials in Behcet's, you've got to find the patients. And that's the hardest part. Most clinical trials, let's say in rheumatic diseases, range anywhere from 500 to 1,000 patients. When we did the relief trial for Premolast in a trial, we had 250 patients worldwide. So one of the problems of doing large clinical trials is you don't have a large amount of patients to do that. And then, of course, finally, we have anecdotal data. So the great example there is the TNF agents, either Remicade or, let's say, for instance, adalimumab or Humira. Those are primarily used for people who develop uveitis. And so we've kind of borrowed from their trials for different disease to apply to Behcet's. So there are different ways of this is going around in terms of looking at clinical trials. But again, one of the problems that we're faced with, we just don't have enough patients to do large clinical trials like some of the other diseases that there are around.
Well, that does make sense. I hadn't thought of it from that point of view.
Yeah.
I'm going to paraphrase a question from someone in here because it is a little bit of a personal question, which we can't ask. But this person does say that they are racially mixed, Black, white, South Asian, Indian, and Bangladeshi.
Whoa.
They're having a hard time getting diagnosed. The doctor that they spoke with spent 45 minutes asking about their family history. This person says they have uveitis, mouth ulcers, skin issues, random paralysis. They want, I think what they want is, do you have any advice about getting diagnosed when they're being told because of their family history they can't have it?
No, that's not true. So remember, genes express themselves in different ways in different examples. I can have a glass filled with gasoline in one hand, and I can have a flame, I can have a lighter on the other hand, but they may never ignite. But you put them together, these two, and they're going to explode on you, right? Same thing with genes. If you put certain gene in the mix, the father may have the fire and he's in the other room. The mother may have the gasoline, but they never meet. They never. But when they have a child, there's where your problem is. So presentation of genetics is an interesting. Now, where your interest is when you mention about Asian, because Asian, particularly Japanese and Korean, okay, more so Japanese, we're seeing much more Behcet's in those patients, but their Behcet's is interesting. They have more gastrointestinal Behcet's. See, not many people. I am lucky because in my area here, I have an Iranian gastroenterologist. He can tell the difference between a Behcet's inflammatory or colitis versus ulcerative colitis or Crohn's. Those patients seem to have much more of those type of conditions, more gastrointestinal conditions. And sometimes it's misdiagnosed as Crohn's. They say, well, this is Crohn's, but there's very specific areas in the bowel this happens. So in your case, it's probably if you're anything from Southeast Asia, that can be a potential problem where there's your market. Now, you mentioned you have mouth ulcers, you've had uveitis, you have skin disease. It's usually typically folliculized. If you have the pathogen, there I'd love to get the HLA-B51 gene. If it's positive, what difference does it make if your family history doesn't have it? You got it, all right? So I never look at the fact that say, oh, you have to have a family member with Behcet's. That doesn't fly. Because again, it's just the right mixture of genes that really causes it, not necessarily that you have a first-degree relative with it.
So it sounds like this person should seek out a second opinion to get.
Oh, without a doubt. If that's the only thing that's holding it back, remember in criteria, if you look at the criteria for Behcet's, it doesn't say family history. So I mean, it's interesting, but I've had people tell me about their family history. I had a lady, this is on a side note. I was asking this person, I said, do you have any psoriasis in your family? And the patient said to me, oh, yes, my brother had it and he died. And I said, well, what happened to him? Because his eyes turned yellow. I go, that's cirrhosis, not psoriasis, okay? Patients, you never know people's family history. You don't know exactly what's going on. So I would not be so, that's not going to hinge on my diagnosis, whether there's a family history or not. That may raise my index of suspicion, but you got enough clinical features to say, hey, now one thing about it is what you're concerned about, someone who having uveitis, and if there is, you want to make sure that you're not developing vasculitis, okay? So the threshold of a Behcet's patient, which is going to get significant disease, is when they start getting into the venal disease, like sometimes they'll see the bruising or the purple marks on the lower extremities of the veins, or God forbid they had a clot, okay, or they had an arterial event. That's a serious threshold that requires very aggressive therapy. So, when you bridge that, okay, that to me, I don't care if you whatever your family history is, that's what's happening to you. I mean, that's really that needs to be addressed.
Okay, thank you. And I just want to ask you, we're getting close to our 30 minutes. Could you give us an extra 5 to 7
Yeah,
minutes?
sure, why not? I mean,
Okay, great.
if
We're
I go
getting,
home early, it's still sunny out there, so my wife will make me mow the lawn. So yeah, I don't have a
got
problem with
it.
that. No.
Well, we have some great questions coming in. One person is asking, with so few treatments available for Behcet's and even fewer that are not off-label, what other relief, holistic solutions, dietary, anything like that, can Behcet's patients explore for relief of their symptoms?
The problem is that's when you talk about holistic treatments, it gets very individual when you have these discussions because the problem is what works for one may not work at all for another. I think that the basic in which area of the body we're talking about. So let's just talk about mouth ulcer because that's the most common thing that we see in all Behcet's patients, right? So when you're talking about holistic treatments, there are certain foods and basically, well, first of all, number one, cigarette smoking. I got to tell you, you got to cut it out. I mean, that's a killer. Okay, I know people come in, and they tell me I had a patient today tell me I said he quit smoking. I said, when did you quit? He said, well, I quit in your parking lot. So that doesn't count. You gotta. That's one thing. So if you're talking about just basically lifestyle choices, really smoking is key. And I may be preaching to the choir, but that's so critically important because that causes ischemia. Okay, it causes the blood vessels to contract, and that aggravates the smoke situation. Plus, the other thing is very important to have good dental. You have to have a good dentist because you can't afford to have bad teeth. If you have inflammation in your gums, it's going to really affect your Behcet. So I have made sure that all my patients, I see either an oral surgeon or a dentist that's familiar with Behcet's. That's the first start. Because if you don't do that, I don't care what other kind of things you find, it's not good. So that's one thing. The second thing I found is with the oral ulcers is that beyond going the holistic thing because you can discuss about foods, spices. I mean, there's a whole. Some people say my doctor told me not to take that. I said, well, did you take it? He said, yeah, it doesn't bother me, so don't worry about it. That's not an issue. But what I will tell you is there's a lot of people that use steroids. Or these oral swish and swirl, and they're good for short term, but long term they can become a problem. So we're looking at different kind of compounds. They're looking at a drug called Carafate in compounded formulation. That seems to work well. The problem with it is that where do you put it, and it's also cumbersome, particularly at night. So the systemic therapies allow us to kind of basically make it so much easier for your life. Okay, so you're not having to sit there and put things in your mouth or rinses and so forth. It depends how frequently it happens too as well. So to ask your holistic situation, I've not found one that says this is the best thing since sliced bread other than stopping smoking and seeing a really good oral surgeon or dentist. That's absolutely critical to do that to prevent the mouth ulcers. But to be honest, it's a case by case basis.
Okay, well, thank you so much for that. There's someone asking if Cellcept is a viable treatment for Behcet's.
Cellcept has been used in Behcet's. It's been used in two areas. One is for the skin. Some people get significant folliculitis and inflammatory change in the skin, so some people will use it. But most of the time, it is a substitute for Imuran. So Imuran, as you know, is azathioprine has been a long-standing drug in patients who develop the vascular complications of Behcet. So if they have acute vasculitis, it's usually steroids plus a drug called Cytoxan. They still use. I'm not been using that much Cytoxan anymore because it is toxic. But Cellcept is a venerable drug. It's certainly well worth using it. It does help sometimes. It doesn't look so great for the joints, but we use it for sometimes the uveitic component. We sometimes use it for obviously if you're worried about a vasculopathy. The problem with Cellcept, though, as you know, is you have to dose it twice a day, and it has some GI issues with it as well. Some people have that, but I've used it in my patients. The only downside of Cellcept that I find is that number one is with a young woman you can't get pregnant on it, where Imuran you can. So that's the big difference when I'm dealing with my female patients. I have to caution them you can't get pregnant on Cellcept. But I mean, it certainly is certainly is a good drug. It's not the fastest drug in the world. That's the other thing. Patients are Behcet's reasonably they want treatment relief now. So it
Right.
takes some time for it to work, but it works for. I like it for the skin. I do, and I do like it for the vasculopathy.
Thank you for that. And I had somebody ask, they couldn't find the question box, but I got it. And it says they were interested about asking you about joint pain and inflammation in particular. Is that associated with Behcet's?
Yeah, correct. So the interesting that we go back to our held back on lupus and Behcet. The joint disease of Behcet's is the most kind of what I call really challenging because we can recognize the mouth ulcers. I can see folliculitis. I can see pathergy. Okay. But the joint symptoms can be fleeting. It can come and go. So the first thing you have to be aware of is when you see this, and it tends to involve the small joints, ankles, wrists. It doesn't always involve the hips. I don't see it. I've seen a knee before, ankles. So these are it's kind of a potpourri in the joints in the area. The treatment there is if it's predominantly joint related, some people will go ahead and use either an anti-TNF type therapy, or they may use, some people use NSAIDs, although I find NSAIDs to cause a lot of GI effects and they can also cause mouth ulcers. So not the greatest thing, but some people self-medicate using drugs like ibuprofen and naproxen. For me, the joint is, again, one of these very specific type of features. What else is going on with the patient? If I have a patient like the patient I mentioned before, they have vasculopathy, I'm moving more to aggressive drugs, and hopefully the joints are treated effectively too. So I have patients on cocktails, literally cocktails. I have them on, and I'm hoping that the apremilast in the data, they did capture joint data, but unfortunately they never published it because that was not the primary outcome. The primary outcome was a reduction or change in mouth ulcers and pain. Those are two things that they looked at. But apremilast is a good. I don't find colchicine to be that effective for the joints. Apremilast maybe, but I'm thinking some of the newer agents that we're talking about off-label may have some help with the joints much better than we would have the previous, because the previous drugs, they're not that effective for the joints. And the other problem I worry about, two things. One is steroids. So sometimes people use way too much steroids. So sometimes you can get away with a low dose, but low dose to me is not great long term. But some people use those to help the joint symptoms. And the second thing that you think about, if you remember, people with Behcet's are normal people. Okay, they have Behcet's, but they have normal other stuff. So when people call me up with a swollen knee, I got to make sure it's not a meniscal tear. I have to make sure it's not an infection. There's a whole host of things. I just can't just say, oh, that's your Behcet's, here's some steroids. You got to be very careful when you have joint disease and make sure there's nothing else going on that's
Right.
not Behcet's.
Right. And I just want to ask someone, it's another medication question. Is there an argument to be made for Remicade infusions over self-injections of something like Humira?
Yes, there is. So the argument, there's two things about Remicade and versus Humira. Remicade is what they call chimeric molecule. It's part mouse and part human. Remicade is more humanized. Okay, so there's some differences between what Remicade is given as an IV, Humira is given based on a fixed dose. So are there differences? Yes, we believe that our more severe patients go on Remicade because the advantage there is I can dose it by weight and I can dose it by frequency. I can change your frequency from any 8 weeks to 6 weeks to 4 weeks, and I can increase it all the way up to 10 milligrams per kilogram. So Remicade seems to have always been kind of embedded in our lexicon as an aggressive treatment, either for recalcitrant uveitis or for patients, obviously, who have even some of the vasculitises that we see, we use Remicade. So it's been kind of a venerable drug. There's no head-to-head. They never compared one to the other, and there never will be a head-to-head. These don't have enough people. On the other hand, with Humira, the advantage there is with Humira is, of course, obviously it's injectable and it's more portable. I mean, people can inject every 2 weeks. Sometimes I've gone weekly on people who have aggressive uveitis. So again, you ask me which is better. The one thing about Remicade I do like is I know the patients taking their medicine, especially my younger patients, my younger males who like to, they'll take some medicine when they're sick and they stop taking it when they're not sick. So Remicade puts people in a chair, makes you see it. And Remicade now comes in, so does Humira, what they call a biosimilar, which makes it less expensive. So we can use it. It's not as pricey as it once was because now they have different forms of Remicade as a biosimilar. And same thing with Humira. I mean, it's Humira now as a biosimilar too, so it's much less expensive to use.
Okay, thanks. And there's a couple of questions in here, so I'm going to put them together about clinical trials. Basically, you talked about the Premalist. Is there a way for people to get involved in clinical trials? And are they mainly in the United States, or is there some
Oh, they're
international?
worldwide. Most of the
Okay.
clinical trials on Behcet's are. I'm trying to get. I'm looking for a clinical trial. They'll let me go to Istanbul. I've never been to Turkey, so
Hmm.
if I could get on a clinical trial, be a perfect. So, but the last clinical trial, they had enough doctors, so they didn't need me. But so the difference is that yes, all of them are worldwide. They have to be because number one, if you got Behcet's in the United States, are you really giving the full spectrum of Behcet's? As we mentioned before, we see in Japan a little bit different. We see definitely different in the Middle East, and so as a result, it has to be a worldwide trial if you're going to do a really legitimate trial. Now, sometimes you can't have enough patients, but the only way you're going to harvest enough patients, it's got to be worldwide. Number one. Number two is in terms of the clinical trials right now. If you go NIH, the NIH website usually will show you what kind of trials there are. You can type in NIH Behcet's trials, and you can get on there and you can see if their trials are enrolling. Now that's through the NIH. Now the NIH also, but it doesn't show and if you register, and every drug company has to register at that site too. So if you're Novartis, you're doing a clinical trial, you have to register, and they would be able to show you what ongoing trials are there and then which are the doctors are doing it. A lot of the doctors in New York, because in New York they see a lot more Behcet's than we see here in the middle, although we see our share, here in the Midwest. Again, Dr. Yutza Yatziki and all his group, they're very famous for Behcet's. Those people aren't usually enrolling in the trial. But then you have to ask what kind of trial you're looking at. Is it purely mouth ulcers, or is it looking at global disease? You can't just look at vasculitis because unfortunately we just don't have enough patients for vasculitis to do a clinical trial and exclude other Behcet's patients. So it's going to be a combination of all those domains. But I'd say we're hoping that two things can happen with Behcet's. One, if we can intercede early in the treatment and change the course of the disease, maybe they won't progress. And number two, we hope that patients never progress to those sites and eventually burn out. So that's our kind of a goal in Behcet's.
Okay, thank you so much for all of that information. I think we're going to wrap up today. If we have a few more questions, we might email them to you and see if we can get a couple of answers to tag onto this video when it goes on to YouTube. But I did want to share here, if I can, before we are done, just to finish up, to remind all of our viewers to visit the Vasculitis Foundation website, because you can find all kinds of information there, including information about Behcet's. For instance, under education, you can learn about information about the various forms, and you could go to the print resource tab and actually print out something to take to your primary care doctor's office or your dentist or your eye doctor about your Behcet's or whatever form of vasculitis you have. Also on the VF website, you'll find a video library with all of the recorded webinars. So the webinars that are on YouTube, you can get through the Vasculitis Foundation website if that's easier. On the home page, you can find out more about the patient support groups and upcoming events like the live webinars, as well as the Vasculitis Foundation, the various conferences that are coming up. And I just want to say, be sure to check out the new and improved Find a Doctor tab on the database on the Vasculitis Foundation website. You can do a search of healthcare providers with experience diagnosing and treating vasculitis. You can click on the Find a Doctor button and it will take you to a step where you can enter your location. Then you can see from this graphic, you can click on filters and pick what kind of doctor you need. So if you need to see a rheumatologist, it's right there. It's a great new tool to help us all find the proper providers for our form of vasculitis. And I also wanted to say that we have a couple of in-person upcoming events that we like to talk about. One is October 11th. The Penn Vasculitis Center in Philadelphia will host the Fall 2025 Patient Education Meeting. And on November 1st, I will be at the Vasculitis Foundation's regional conference at the Medical University of South Carolina in Charleston. I hope many of you will also. And I'd also like to let our viewers know that at the end of this video today, this recording, this webinar today, you'll get a survey that'll pop up. It'll say continue. We want you to press that button, continue, and take the survey. That's something that we really need. It's important to the webinar program. The one thing we want to hear about especially is your ideas for future webinars. So please press that continue button and take the survey for us. And of course, we'd like to thank the Vasculitis Foundation for hosting these medical webinars, our sponsor, Novartis, and Dr. Sulich. Thank you so much for taking the time with us today. You were great. You answered all of those questions so wonderfully, and the patients were very thankful for your time with us today.
Thank you. I forgot one more thing, very important to me.
Yes.
A part of talking about Behcet's, you tend to look like a disease more than a person. That's wrong. It's very important for the one thing we doctors are terrible at is the mental health component. The depression, the loneliness, anxiety, fear, that has to be addressed. And I think sometimes the doctors or even patients minimize that. And so I always have this discussion with patients when I have the time to say, look, this is very important. And if you do have, which you will, I mean, you're with having to deal with this illness, I think it's important to work with also a mental health specialist. People think that, well, you think I'm crazy. No, no, no. That's the exact opposite. I think it's very important that that component is also addressed because I've lost patients, Behcet's, to suicide. And it's something that, I still see their faces and I kind of tear up when I see it. So it's really important that that's addressed. And sometimes in a busy clinic or something like that, we don't have time to talk about it, but I'm spending more and more time talking about the mental health aspect of it. That's extremely important. Thank you.
Well, thank you so much for mentioning that and for looking out for us as patients. And I also would like to echo that by saying the patient support groups through the Vasculitis Foundation are just wonderful.
Thank you.
So thank you so much, Dr.
Thank you.
Sulich, for your time with us today. We really appreciate you and all that you've given us today.
All right. All the best. Thank you. Thank you, Catherine.
Bye.
Thank you, everybody. All right. Take care. All right. Bye-bye.